All right, well, I guess we'll go ahead and get started just because there's a lot of stuff in this. There are 60 slides in here, and I'm going to be able to probably zoom over a couple of them, but some of them we're going to have to spend some time on. So we're going to talk about pediatric sepsis. I feel like I've given this lecture to you guys, I don't know, 5 times in the last 2 years. So if you're a third-year resident, you could probably recite most of this stuff back to me, hopefully by now. But we're just going to talk about ped sepsis, and why we're going to talk about it is because, you know, this is something that unfortunately is missed too frequent of amount of times, despite the fact that we now have EHR alert systems and everything. So here are our objectives. We're going to talk about how sepsis is difficult to identify and detect, and it's deadly if it's missed. You know, there's a kid in the PICU right now who was actually identified and still quote unquote missed. So we're going to talk about incidence mortality statistics, define SIRS, sepsis, severe sepsis, and septic shock in pediatrics, as we don't even talk about that in the adult literature anymore. We're also going to talk about why SIRS is not really the best way to detect sepsis in pediatric patients, discuss the physiologic changes associated with sepsis, and recognize the importance of how early aggressive IV fluid rehydration and antibiotic administration will absolutely decrease the morbidity and mortality of the patients that you're seeing. And we're going to just review the current evidence for treatment. So we're looking for needles, okay? Pediatric sepsis is not something that we really encounter on a daily basis. It's, you know, we see kids every day with fever, and we don't see kids with sepsis every day. So, but the problem is what do we have to use to identify that can kind of help us identify these patients who are either at risk for sepsis or in early sepsis? There's about 50 to 70,000 cases of hospitalized sepsis every year in the US. Overall costs near $5 billion. Sepsis is the leading cause of death in children 1 to 4, and mortality is highest in children less than 1. And overall hospital mortality is approximately 10% of patients. The other purpose of this talk, and you know, since we've switched EHRs and now we used to have the Cerner-based alert system, and now we have the Epic-based alert system, and we're having some growing pains with that right now. But there was a recent study that was published out of Boston Children's. It was either January, February of this year. They basically compared their pre-go live data where they manually screened patients for sepsis, and then compared it. They had the Cerner-based alert and compared it to the Cerner-based alert system. And essentially they identified a ton more patients. Their sensitivity went from 60-ish% to about 85 to 87% by using the computer-based algorithm. So despite the fact that some people don't like the EHR alert system, don't think that it either catches too many patients, it's still better at identifying patients that are septic than just us doing it alone. So please pay attention to it. So how do we define all these things? SIRS, sepsis, severe sepsis, and septic shock. So I have been giving pediatric sepsis lectures since I was a fellow in 2014. And despite the fact that it's 2021, I'm still using the same exact slide from 2014. Okay. So SIRS is a clinical response with greater than or equal to of the following: either a fever of 38.5, which is 101.3 for your children over 1 month of age, or less than 36 degrees centigrade. Your heart rate is greater than 2 standard deviations above normal, or any bradycardia in children less than 1. Your respiratory rate of greater than 2 standard deviations above normal, or there's a need for mechanical ventilation, or there's leukocytosis or leukopenia, or there's greater than 10% bands. Sepsis is nothing more than SIRS with a suspected or proven infection. So that's it. Okay, you have a SIRS kid with a known infection, then you have a kid that's septic. Severe sepsis is either they have cardiovascular dysfunction, ARDS, or greater than or equal to 2 other organ dysfunctions. And then septic shock is that it says despite IV fluid rehydration and resuscitation of greater than 40 mLs per kilo, despite that, child still has evidence of cardiovascular dysfunction, usually meaning by hypotension, and they're going to need vasopressor therapy, and that is septic shock in children. So SIRS, again, we'll talk about that. So fever or hypothermia, tachycardia or bradycardia, tachypnea, or they're needing some form of mechanical or even non-invasive ventilation to kind of maintain normal respiratory rate, or they have leukocytosis or leukopenia. But the difference in kids, though, is that just tachycardia and tachypnea alone is not SIRS. Okay, you have to have at least the fever or the hypothermia or the leukocytosis or leukopenia. So you either have to have, you can't just say, oh, the kid's tachycardic and tachypnic, they have SIRS. Okay, because every child that comes into the triage room in the PZR that screams has SIRS. Okay, because they get, a kid that comes in with a facial laceration, that comes in with a heart rate of 180 and a respiratory rate of 50, by definition would have SIRS if you included just those two. But you have to say one of those plus either a temperature abnormality or a leukocyte abnormality. So here's a quote from SIRS, is that it's very commonly manifested in otherwise well febrile children and even in children without infection, leading to low specificity and limited use to clinicians. So just because somebody has SIRS doesn't necessarily mean that they're septic unless you have a suspected or proven infection. And like I said, you're going to have a lot of kids with SIRS, which was the huge, like when we first went live with the EHR, everybody was like, every kid's going to make this alert go off. Like every kid that comes in here during, pre-COVID flu season, it's like every kid that rolls in here with flu is going to have SIRS, and we're going to have to be doing all these screenings and giving all these unnecessary antibiotics. Well, that's not necessarily the case, because you can huddle and you can communicate with your healthcare providers and just be like, look, this is not really sepsis, this is something else that's going on. So in 2005, it was SIRS plus suspected or proven infection. In adult population, they now changed it to a defined life-threatening organ dysfunction caused by a dysregulated host response to infection. So that's the adult population. And then the kids, they changed the definition to, well, we need to just kind of update the definitions. And that's basically what they said. So we really don't have a whole lot of new information. I was doing some literature search again before this. Nothing really has changed as far as our management, as far as the definitions of pediatric septic patients, because right now, all the recommendations we have to go on are low quality evidence. They're based on expert opinion. They're extrapolated from adult literature, and that's basically it. Okay. So let's take a look at the pathophysiology of pediatric septic patients, and then we'll talk about the guidelines and treatment algorithms. So this was actually a picture that was given to me from fellowship, and it really hasn't changed. So basically, it's all about a dysregulated host response to an infection. That's the adult population, but really that's what it is. And so what the problem is it's all about inappropriate oxygen delivery to the periphery, to the tissues, to the end organs, okay? So if you have inadequate oxygen delivery, you have tissue ischemia. If you don't have the nutrient supply to meet the oxygen demand, then you have a problem where you switch from aerobic metabolism to anaerobic metabolism. When you switch to anaerobic metabolism, you decrease your ATP production, which leads to all of these byproducts like lactic acidosis. You release all these inflammatory mediators, and basically things just don't work as well as they should, okay? So I'm going through all of this, and this is all like your test question stuff. These are things that you're gonna need to know for the answer for the test. When I was thinking about it and I was going through it again this morning, you don't necessarily have to know all of this pathophys to successfully treat a pediatric septic patient. You just have to know what to do and how fast to do it, okay? And so that's really the most important part of this entire talk. You can look at all these slides 2 weeks before you take your boards, and you can get the questions right on the test. But when you're looking at a septic patient in front of you, you're like, okay, this kid needs 60 per kilo of fluids in 60 minutes. We need antibiotics on board yesterday. Okay, and when he's done with volume resuscitation and we're looking at him every bolus to make sure the liver's not getting big or JVT's not developing or the kid doesn't develop a gallop. And if we are, we're going to slow the fluids down and we're going to start pressors. Okay. Literally, I could do this talk in about 5 minutes. Okay, and that's literally all you really need to understand how to do. And I know I'm digressing, and I'm going to jump again on my on a different soapbox. Communication with your nursing staff is the most important thing that you can do to successfully treat a septic patient, especially on the floor, especially in the middle of the night. Okay, so face-to-face communication with somebody saying, "Hey, I'm really worried about this kid. Something's going wrong. The labs look all wonky. The kid's persistently tachycardic. Let's do something about it." And that is your huddle. Okay, that's what that is. That is you determining something needs to be done and whether or not the patient needs to have a rapid response and go up to the PICU or go up to double I status where they can be monitored more. That's a conversation to have on a patient-to-patient basis. So back to the lecture now. That was probably the lecture, what I just said. But back to the PowerPoint lecture, which I do not like to do, by the way, and putting me behind this podium right here is not something that I'm happy with. This is something just for you to remember, to kind of recall if you ever have any issues with, is this really tachycardia or this is just really tachypnea in these patients based on age? So that's the chart there for you to kind of review. So again, sepsis is SIRS in the presence of a suspected or proven infection, or the adults have changed it to a life-threatening organ dysfunction caused by a dysregulated host response to infection. And then severe sepsis is sepsis plus some form of organ dysfunction. And if it's cardiovascular dysfunction or pulmonary dysfunction, then you have severe sepsis. Or if you have greater than equal to 2 other organ dysfunctions, whether you're coagulopathic or you're having some sort of liver failure, something like that, that can give you a severe sepsis definition as well. The one thing I have not mentioned to you yet is that in any pediatric patient, hypotension is not required to diagnose clinical sepsis or even severe sepsis, okay? Septic shock, yes, because if a patient has gotten 40 per kilo of fluids and they're still hypotensive, then that is septic shock, okay? But a kid can be septic and have a normal blood pressure. A kid can have severe sepsis and have a normal blood pressure, okay? So basically you have this inflammatory triad. So you can have a kid who's febrile, who's tachycardic, and has some evidence of altered perfusion. Say their cap refill is a little bit delayed. Say it's like greater than 3 seconds. Well, that's a problem. A kid is inappropriately, inconsolably irritable. That's a problem. It can be a sign of poor perfusion. If they're drowsy or confused or lethargic, any sort of mental status change, that is a problem as well. So inadequate perfusion is altered mental status, a delayed cap refill, a diminished pulse, some mottled or skin changes, cool extremities, or you could have something called warm shock, which is where children come in and they're extraordinarily hot and their periphery is just red. I mean, it just looks red. And they just have flash cap refill. You press on them, as soon as you let go, it fills back up. And they have really, really bounding peripheral pulses. So your physical exam on clinical signs of shock, you have an altered kid who could be listless or toxic appearing, or they could just be irritable and fussy. They could be tachypnic and tachycardic. They could have difficulty with breathing. They could be grunting. They could have just poor tone and not want to stand up for you, or they just have poor tone and won't sit up for you if they're younger. Warm shock is going to be a flash cap refill with warm extremities and bounding pulses. Cold shock is going to be a delayed cap refill greater than 2 to 3 seconds, cold extremities and weak pulses. Hypotension is extraordinarily delayed in children. If you have a hypotensive pediatric sepsis patient, you have not started antibiotics and fluids yet, you are behind. You are way behind, okay? And then oliguria, if a kid's just not making urine. It's difficult to kind of assess that immediately upon arrival. You can ask parents, like, how many wet diapers have they been having, stuff like that. That can give you a good idea, but you're not really going to know if a kid is oliguric until like you're able to get them admitted for 24 hours and realize what their urine output is. How do you diagnose hypotension? So it's 70 plus 2 times the age, or anything less than 60 in a child less than in a neonatal age group, okay? Septic shock is sepsis with presence of perfusion abnormalities despite volume resuscitation. So you have warm shock where your cardiac output is through the roof, your systemic vascular resistance is low, so everything is peripherally dilated. You have increased pulse pressure, you have warm extremities, and you have flash cap refill. The late stages of the cold shock is where your heart is starting to dysfunction. You'll have hypotension. You'll develop the anion gap acidosis due to buildup of lactate, cool extremities, and delayed cap refill. You have tissue ischemia, and you have inappropriate use of glucose, or basically just not enough substrate to produce any energy. So this is basically the chart scene of what I just said. Okay, so I can still remember this when I took my boards in 2015. I got this chart as a question with some arrows missing. Okay, and then it was like A, B, C, D, and it was like, up, down, equal, 2 ones up. It's like, okay, great, appreciate it. Thanks for my photographic memory. I think I got that question right. So what do I order? All right, you basically order as much stuff as you want to, okay? This is one of those things where nobody's really gonna get on you for ordering a test. Star Wars might be like, now, what did you order that for? He probably still would say that, but still. So white count, complete metabolic panel, you're gonna get a ProCal or CRP or both. When I talk to the EM residents about white counts and inflammatory markers, they're like, well, which one do you like? And I'm like, I like all 3 together at the same time. Why? Because it's the most information I can get on a patient, okay? And all I really want is one of them to be abnormal. I could care less. They're like, well, the white count's normal. No, I don't care. CRP is greater than 320. Something going on, okay? So lactate, I'm kind of plus or minus on the lactate. The reason why, if you have an older kid who has a free-flowing IV, feel free to grab a lactic acidosis. Check for lactic acidosis. If you have a young kid who is somebody's got a shorty 24 and they're in the left side of their foot, and they're having to squeeze to get it out, don't worry about it. Okay, it's not going to really matter to you. You're going to be able to see their metabolic acidosis. You're going to be able to see all the other things. Okay, It's not on the ped sepsis order set. So if you think about it, you can one-off it if you have an older kid with a free-flowing IV. Coag panel for DIC, urinalysis, obviously for signs of infection. You're going to check usually a cap gas, just kind of see how they're exchanging, make sure everything's fine. Obviously blood cultures ×2, grabbing a urine culture, tapping if you need to. If you have another source of infection you're concerned about, either a wound or a stool culture. Type and screen, because sometimes these kids need blood, despite the fact that you give them all this volume, dilute their hemoglobin out, and all of a sudden you diminish their oxygen delivery because they have no box cars. And then in the post-COVID world, everybody's always thinking about MIC now, which can absolutely look like toxic shock. And I've seen several kids with it already. You're going to check D-dimer for fibrinogen, troponin, and then you're going to check the SARS-CoV-2 antibodies. Okay, so that's just one addition to the complicated issue that we have now with dealing with septic patients. Like, not only could this be sepsis, but is this MISC? Okay. So other potential diagnoses besides MISC. So if you have a kid who's irritable and fussy and has hypothermia and looks kind of weird, is a little bit mottled, could that kid be abused? Yes. Okay. If you have a kid who's irritable and fussy, and let's say they're having a little bit of vomiting too, and you're like, man, this kid might have meningitis, and you roll them over and all of a sudden they have a current jelly stool. Perhaps intussusception should be on your radar a little bit for these patients. Any sort of drug ingestion will also kind of cause this, depending upon the type of drug that they're ingesting. I've had clonidine ingestions that have really looked like, for all the world, sepsis patients. Myocarditis could absolutely look like a kid that's having, they have the cardiovascular dysfunction. They're going to be inappropriately tachycardic because their myocardium is swollen from lymphocytic infiltration. And so they're going to have a really, really high heart rate. Their stroke volume is going to be terrible. So myocarditis is something to always think about. In the neonatal age group, a PDA-dependent congenital heart disease, and the PDA is closing, so you got a coarc, and it's a critical coarc. And all of a sudden the kid rolls in and you're like, woo, what do I do? It's always good to check pre and post-ductal stats and forward extremity blood pressures on your neonate patients that look like they're septic, just to kind of complete, your differential diagnosis. Adrenal crisis, hopefully. You either have a history of this, or it's a kid that you're working up as a neonate and you're like, could this be CAH? I don't know. The kid comes in, for all the world, they look septic. And despite volume resuscitation, it's a problem, and they're on vasopressors, but they're still kind of hypotensive, and you're like, should I be thinking about hydrocortisone? Okay, and that's kind of where you are kind of towards the end of this. The recognition of severe sepsis, definition of organ to system dysfunction. So basically, I'm going to run through like all of the different organ systems and what their definitions of dysfunction are. Cardiovascular is pretty intensive. So despite 40 mLs per kilo in the first hour, you still have hypotension, or you need pressors. Done. Okay. Or you can get two of the following. You have an unexplained metabolic acidosis. Your lactate's 2 times the upper limit of normal. They're still oliguric despite the IV fluid resuscitation. They have a greater than 5-second prolonged cap refill. And there's actually really good evidence about core to peripheral temperature discrepancies. Okay. So if you check a core temp and then you check an axillary temperature, and there's a pretty wide gap, that child is in cold shock. Okay. So just make sure that if you ever have a question about it, it's not something that's difficult to do. Just be like, can I get a rectal temp and axillary temp? I just want to compare the two real quick and make sure that we're not in cold shock. Respiratory dysfunction, PaO2 to FiO2 less than 300 in the absence of cyanotic heart disease. PaCO2 greater than 65, or there's 20 if you have your special needs children who are trach, and they have a baseline that's abnormal. It's 20 off their baseline. Their need of FiO2 greater than 50% to maintain a SAT greater than 92%, or the need for non-elective invasive or non-invasive mechanical ventilation. Neurologic dysfunction, I think this is a great definition, but I would say any child that you would deem not at their baseline should basically be neurological dysfunction for you. Okay, I don't care if GCS is 11 or 12. The definition says GCS less than 11 is neurological dysfunction. However, if you have a listless, irritable child who is not acting appropriate for their age, we have a problem, and I would say that there's neurological dysfunction there. Any acute change in mental status with a decrease in GCS greater than or equal to 3 points from baseline for those special needs kids. Hematologic dysfunctions, platelet count less than 80 or decline of 50% in baseline if you know it, or if their INR is greater than 2. Just coming from the ER, I know the nurse pushback that you will get with trying to fill up a blue top on a baby, okay? In the setting of a severe disease like sepsis, where it could be life or death, and you're worried this baby could be coagulopathic, it's absolutely something that you need. okay? So politely tell them why you're getting it, that you're looking for organ dysfunction and you really need that blue top filled all the way up, okay? Renal dysfunction, creatinine is greater than equal to 2 times upper limits of normal, or a 2-fold increase from baseline if you know it. Hepatic dysfunction is a Billy greater than 4, or an ALT that's 2 times the upper limit of normal for age. Obviously, they change based on time, how old they are. And this is basically the summary of that. So cardiovascular is hypotension with 2 of the following, either a low bicarb, a high lactate, prolonged cap refill, or a high quarter peripheral temperature gap. High INR for hematologic, or they're just thrombocytopenic for some reason, you can't explain it. High bilirubin, high LT. Neurologic is lower, largely increase in GCS. Renal dysfunction, which is a large increase in the serum creatinine. Or if you have a patient who you're having to throw on either a non-rebreather, or you have them on a 50% FiO2 venimass, or you're thinking about putting them on Vapotherm because they're so tachypneic, like that's respiratory dysfunction, okay? So here we're going to talk about the treatment. So all you people in the Zoom world, please focus for me just for 1 second. All right, so we're going to talk about the treatment of shock. General principles always apply, okay? In the setting of a truly sick child, when people are running around like crazy, stop and just remember your ABCs, okay? Is the child breathing appropriately? Does the child need intubation right now? Is the child really too tachypneic? Do we need to be placing them on supplemental oxygen? One would argue yes for just about all of these kids. And then what's their circulatory system status at this point? Like, you're just looking, are they hypotensive? Are they really tachycardic? Do they have a really poor cap refill? And so your job to treat these is essentially to increase oxygen delivery by improving cardiac output, improving the amount of oxyhemoglobin by giving them some form of FiO2 support. And you're going to decrease their oxygen consumption. You're trying to slow them down. You're trying to lessen their metabolic demand so you can meet their needs. So you want to make their temperature normal. If they need to be sedated because they're too irritable, too fussy, or something like that, or do you need to just go ahead and perform RSI and get them intubated and sedated? I don't care what the cause of the sepsis is, okay? I don't care. I can tell you how many times when I'm ordering this bundle on a patient, unless I know absolutely what's going on, the child's getting vasopressors, okay? Because that is your undifferentiated, like what's going on, broad spectrum antibiotics for your child less over 30 days of age, okay? Neonates, a different story. We'll talk about antibiotics for them. But it's not necessary to determine what exactly you're treating for your first antibiotic dose, okay? And that's what I tell everybody downstairs. So I was like, we're the door, okay? We don't know. A lot of undifferentiated stuff going on. I don't care if you're going to put me through the retrospective and be like, you should have just given them ampicillin because it was obviously pneumonia. I don't care, okay? It's not my problem at this point. Got a septic kid in front of me. I'm trying to get antibiotics. All etiologies of shock involve some form of lack of oxygen delivery and some lack of substrate, all forms, okay? Your goals in the first hour are to maintain your ABCs. You're going to maintain your age base, and you're just trying to normalize everything that's abnormal. You're like, okay, temperature is wrong, got to fix that. Patient's too tachycardic, got to bring that down to normal. Blood pressure's low, got to bring that up. Patient's too tachypneic, trying to normalize that. That's really all you're doing. Patient's not peeing, want to see a wet diaper. You know, that's really all the things that you're looking for. So here are your goals, what I just said. You want to either maintain a normal mental status or make them normal. You want to normalize their vital signs. You want to improve their cap refill. You want to make sure your central and peripheral pulses are equal. You want to close a gap if you have one. You want to decrease the lactate if you order one. And you want to maintain euglycemia. You're giving all this isotonic fluid to these itty bitty babies, okay? They don't have good glycogen storage, all right? They're already probably utilizing all of their storage that they have. So bolus them, put them on some maintenance fluids or 1.5 maintenance with some dextrose in it. That way they actually have some substrate to deliver to the tissues, okay? You can do all of that at one time, all right? The one thing that I kind of have to keep telling the EM residents downstairs is, I know that Ringer's lactate is a better IV fluid choice for these patients in terms of their outcomes when you look at the adult literature, okay? Problem is in real world, where you only have 1 and maybe 2 access points on a pediatric patient, lactated Ringer's has a lot of problems with being compatible with a lot of your antibiotics and your other infusion agents, okay? So if you only have 1 access point on a patient, use saline, okay? They just really need volume. We've had to go back and cancel things. For one, so you can't use LR and order Rocephin. So if you order Rocephin, they either get in the fluids and the fluids have to stop and then they get Rocephin. Okay, but if you order saline, they can get it all at the same time. So what are the 2 treatments which should be started in the first 60 minutes of a septic pediatric patient? Fluids and antibiotics. Okay, great. So adequate fluid resuscitation. Yes.
Not oxygen?
Not oxygen?
Yeah, wouldn't oxygen be one of the things that
You
should
can-
be started?
You can absolutely put the patient on supplemental oxygen. It's like to increase oxygen delivery, that's fine. But as far as what are the treatments you're going to do to kind of reverse this pediatric sepsis is going to be volume resuscitation and antibiotics. Because we already did the ABCs way back here. So once you put the patient on oxygen and you're already putting IV access on them, and like if you have a truly septic patient, they're really difficult to stick. Do not be afraid to put an IO in a kid like this. Okay. You're like, okay, we stuck this kid 14 times. We run out of access points. Drill IO and a tibia, call it a day. Okay. All right. So fluid resuscitation. This is the hallmark of shock resuscitation in children. Okay. Cardiogenic shock, we can talk about that later. All right. You figure that out. You give a bolus. You're like, ooh, got a gallop and the JVD's showing up. Maybe you should slow down a little bit. But for right now, you know, just about in everything else, it's going to be volume. It's going to be your friend. Okay. You can give up to 200 mLs per kilo in the first hour, but usually you're going to give 60. Okay. You want 60 mLs per kilo in 60 minutes. All right. And how you do this is you give 20 mLs per kilo every 20 minutes. All right. So you give 20 and 20 times 3 equals 60. Rolling. All right. We're doing great. Yes, ma'am. So the rule is, you mean to tell me what the real rule is? The rule is 3 attempts or 90 seconds. That's what the rule is. That's what you're supposed to do. Okay. We obviously don't really adhere to that rule 100% of the time. Sometimes you're like, oh, it's been 5 minutes. So if you have a patient who's been stuck 3 times, it's kind of like 3 strikes, you're out, put the drill in. Okay. Especially if you have an unstable patient. If you have a patient who has a heart rate of 200 and a pressure of nothing, and they're listless and lethargic, and you got a crying mom over there, she's gonna be freaked out by what you're about to do, but you tell her that it's to save your baby's life. Okay, and so that's how we're supposed to do it downstairs. It's supposed to be 3 attempts in 90 seconds. How we do this? So I don't know if you've ever seen the pushing technique. So so we have that little device where you pull it out of the volume of the bag and you push it into the patient. You pull it out, it's just a little, all it is a little stopcock that you just turn one way and then turn the other, and then turn one way and then turn the other. In neonates, you literally just grab some 10 cc flushes. And you just start, like, I don't know how many times I've done that. I'm like, bring me 10 flushes. Okay. 10 flushes, 60 per kilo, we get. Okay. And so that's kind of how you're going to do it. And so aggressive volume resuscitation, I'm telling you, that is really the one thing that's going to improve your survival the most. Antibiotic administration is a very close second, though. And we'll talk about that in a little bit. So antibiotic administration, age dependent, broad spectrum antibiotics. Your first choice is really going to be the big choice. You're going to tailor therapy once you figure out what in the world is going on. But how do you decide what to give? So at this point in time, this is one of those things where, making a wrong choice, I can't believe you gave that kid Rocephin. It doesn't, you still covered it. Okay. And that's 1 dose of antibiotics. They don't necessarily have to be on it every single time. Once you actually get some information back, then you're okay. All right. So now that we're in Epic, here's a screenshot of your order set search. And literally all I did was type in sepsis. Okay. So you have several different things to choose from right there, but the one you're going to pick is that one, the IPP sepsis diagnosis and treatment bundle. Okay. If you look above it, like I think 3 lines, there's the EDP sepsis SIRS. It's terrible. It's being redone. Okay. It was shared with us from the upstate, but the upstate never really utilized it. And so it was kind of out of date and incomplete. And so it's being revised. We've actually met with them and had an online Zoom call to kind of change that. So when you come downstairs to the ER, it should be live here in the next couple of weeks. It shouldn't be, so you wouldn't have to worry about it anymore. But the problem is we can't use yours because yours are inpatient orders. So it would have been nice to, I was just like, we're just using inpatient when they're like, actually, you can't. I'm like, what do you mean I can't? There's still orders. Anyway, whatever. So for the people in the back that can't read what that says, that's what it says. Okay. IPP sepsis diagnosis treatment bundle. Please use the bundle, people. All right. 2 things. Use the bundle, huddle with your patients, communicate. Okay. Communication is key. All right, so I know this is kind of small, but basically here it is. All right, so it's giving you everything. It's telling you what to do. Remember rapid boluses, how many to give, how much to give, because your other labs and everything. Talking about phase 2, which is treatment. Look at all this guidance they decided to. Free text in there. Just read it. Take 30 seconds. Figure out what you want to get. Okay. Obviously, it says contact Peds ID if you need to. So it tells you what it's not intended to use for. And basically, you're going to use the things that they say, which are going to be right here in your infants less than 30 days old. You're going to use ceftriaxone or cefepime, and ampicillin or possibly acyclovir. Here's the problem I have with this, okay? Total bilirubin less than 5, use Rocephin. I'm not waiting on total bilirubin to come back to start antibiotics on a septic neonate, okay? So my first choice is going to be cefepime. We'll figure it out later. Y'all can be like, you know what I mean? Like, that's just it. Like, I'm not going to sit here and wait for a total bilirubin to come back to figure out if I can give Rocephin or not. So the kid's going to get cefepime because my 60-minute window is going to be closed by the time that lab comes back. So AMP, cefepime, possibly acyclovir if you're worried about HSV. Infants greater than or equal to 30 days, you're going to use Rocephin, like I said. Usually the most common 2 antibiotics that I'm going to order downstairs because I don't know what's going on. Here are all your alternatives. I'm not going to read them to you, but this is on the order set. So as you go from phase 1 to phase 2, if you need additional coverage for different, if you have a concern, say you have a post-op patient, I don't know, something like that. Say you have a patient that you're concerned about having, you know, if you think they have osteo, obviously you're already giving them vancomycin, so it's not a problem. But say you have a patient who has grown out Pseudomonas before, and they're septic, and you know, so you instead of giving Vanc and Rocephin, maybe you should give Vanc and Cefepime. Okay. But why? Why? Tell me why. Why are we doing all this so fast, and why do we not care what antibiotics we're using? And that's because if you delay, kids are going to die. Okay. So more than a 3-hour delay of appropriate antibiotic administration after sepsis condition was associated with a significant increase in PICU mortality, and these associations persisted even after they adjusted for any other confounders. What I want you to notice in this picture right here is not necessarily the black line that goes up, but look at the percentages, okay? The percentages of mortality. So the number of patients, look at greater than 3 hours. There were 52 patients who had greater than 3-hour delay. They had a 21% mortality, okay? So they lost a fair amount of those patients in that group. You know, you're going to lose patients at every group because the patients that hit the door that are obviously septic, that are honestly they're past the point of no return and you know it, you know, but you're going to do everything you can as quickly as possible and give them all the volume and do all the things and intubate the patient and put them on vasopressors. Despite all that, you may lose, okay? Sometimes the bugs win. So early reversal equals improved outcomes. This was a 9-year retrospective study involving 91 patients. Notice they took them 9 years to get 91 patients. Their overall mortality was about 29%. They achieved shock reversal in about a quarter of the patients within an hour and 15 minutes. Then that was associated with a 96% survival and a greater than 9-fold increased odds risk of survival. So if they literally had shock reversed in an hour and 15 minutes, 96% of those kids survived. Each additional hour it took to get them reversed was a greater than 2-fold increased odds risk of mortality. Non-survivors got less fluids compared to survivors. It really wasn't a ton of difference, but it was still 32.9 mLs per kilo versus 20 for the children that died. So 1 bolus of fluids versus 1.5 boluses of fluid. And resuscitation followed guidelines in only 30% of patients. Okay, so, and this is not like a small, like podunk, like itty bitty hospital. This is like tertiary referral children's hospital. Sorry for the red, but this is your goal. Your goal is to fix what is abnormal. If you know, you walk in the room and you're like, kid's too tachypnic, we got to slow that down. Kid's too tachycardic, we got to slow that down. Kid is febrile, we got to make that normal. Kid's hypoglycemic, we got to give them some dextrose. Way dry, needs lots of fluids. Okay, and then obviously antibiotics, and then oxygen if you need it. As far as, you know, one would argue, despite the fact, even if somebody has a normal oxygen saturation, you would still put them on supplemental oxygen just to increase oxygen delivery. Okay. So studies on lactate clearance, I don't really have to go through that. But basically, you know, the faster you clear lactate, the more likely kids are to survive. That's literally the end all be all of that. However, in those young patients, you may not actually have a lactate to even go on. So we're going to talk about, so after you've given the fluids, the 40 to 60 mLs per kilo within 30 to 60 minutes, you've given your antibiotics, and the kids You're trying to stabilize the kid, but you're still meeting, maybe they're meeting criteria for septic shock at this point because you've already gotten the 2 boluses in, they're still hypotensive. So what are you going to do next? So oxygen, fluids, antibiotics. What's next? Pressors. Okay, so we're talking about vasopressors for kids who are persistently hypotensive. So you basically hear the big 3 that we're going to use, maybe. So dopamine, epinephrine, norepinephrine. Anybody have a choice? Anybody know what they would pick? Anybody know what they would roll out? Depends on the kind of shock is an excellent question. Okay, the answer is yes. So what does this evidence say? So we'll talk about that right now. So here are 2 randomized controlled trials comparing dopamine to epi as the first-line agent in pediatric septic shock. So the first one, basically the primary outcome for the first study, the Ventura study, was 28-day mortality. Okay, so the higher the mortality or the higher the number, the worse that pressor did. Okay, the second one was the primary outcome was the rate of shock resolution. Okay, so 28-day mortality, 7% mortality on epi, 21% mortality on dopamine. So which one was better? The epi. Okay, second study, rate of shock resolution. So what percentage of patients achieved resolution of their shock with the addition of this pressor? So you want a higher number. So 41% of patients on epi-drip had shock reversal versus 13% on dopamine. Is anybody picking dopamine? Dopamine should not be used in treatment of pediatric septic shock ever. Okay, it's never your choice. Okay, if it's ever on your test, just scratch right through it because it's the wrong answer. All right. All right, so I really want to kind of go back here. So somebody asked the question, it depends on what kind of shock it is. So remember at the beginning when we talked about cold shock versus warm shock, right? I know we're all pediatricians in here except for me, who has some adult training as well. What is the first line vasopressor in basically anything adult? Norepi. Okay, so basically everybody's using levofed around here. Don't matter, you can put some levofed on them. You know, cardiogenic shock levofed, even though dobutamine sometimes is a better choice. You know, so it's like levofed. So levofed is typically your first kind of like first line vasopressor for just about anything. So you have epi and norepi, and then you have cold versus warm shock, and you have to match one of them up to one of them. Okay, so which one is which? No. So you can use them both on both, but there's one that's more preferred for warm shock and one that's more preferred for cold shock. That's right. Okay. All right. So norepi causes more peripheral vasoconstriction. So if you have a child in warm shock, norepi may actually not be a bad choice for you to basically increase the systemic vascular resistance in order to increase your blood pressure. Okay. All right, if you have cold shock, give them one, put them on epi, it's fine. The PICU loves epi, put them on epi, we put them on epi. You know, if a kid truly has flash cap refill though, and it's very, you know, has a very, very warm periphery, put them on norepi. But dopamine is never your choice. Yep. Because one's maxed out, maybe. I mean, yeah. I mean, you're going to start. So typically, the rule is you're going to put somebody on 4 pressors before you're like, we're done. Like, there's nothing else we can do. So you're going to put them on, you know, epi, norepi, vasopressin. Probably throw some hydrocortisone at somebody, you know, and then maybe somebody mentions phenylephrine, you know, and once you put them on all those things, you're like, there's nothing else we can do. So like this is profound shock that's irreversible. Refractory septic shock, assess the need and indications to give steroid therapy in children who are hypotensive with poor perfusion despite all the volume, despite all the vasopressors, especially if they have obviously purpura, history of chronic steroid therapy over known pituitary adrenal abnormalities. You're going to give them hydrocortisone, dose 4 mg/kg, max dose of 100. I know some of them are based on milligrams per meter squared. Trust me when I tell you, I know this. We're never going to hit that. I'm never going to be able to measure a child in the ER. This is what I give. Okay. You're like, somebody measure it for me. All right. So here's a kind of a quick case scenario. What's going to happen? So your patient arrives. You realize something's going on. They have fever. They have poor perfusion. They're altered. You assess your ABCs immediately. Put on supplemental oxygen. You're like, do they need intubation? We'll see. Okay. Hopefully you get an IV in really quickly. If not, 90 seconds or 3 attempts. You're going to put an IO in, you're going to give 3 20 per kilo boluses every 20 minutes for 3 times. It equals 60 per kilo in 60 minutes. You're going to order your undifferentiated sepsis antibiotics, which are going to be vancomycin plus or minus anything. If that child has some sort of past medical history, that's going to clue you in that you may need to add something different. You're going to order all of your labs, all of your films, everything that needs to be done. Every time you finish a bolus, you need to go in and reassess that patient. Is the liver down? Do they have JVD developing? Do they have a gallop? Are they increasing their respiratory distress, despite the fact that you are doing things that supposedly should be helping them? Okay. Are they fluid responsive? Did you normalize? Are they still having cardiac dysfunction? So if they're fluid responsive, yes, then you continue volume resuscitation. If they're still hypotensive or showing signs of shock despite volume, you're going to start peripheral epinephrine while establishing central access. Yo.
At what point is testing
In the ED or in the floor scenario? So if you're on the floor and you got a kid who's altered with poor perfusion, I would call them then and be like, here's all the stuff we're about to do. This kid can't stay here, okay? Like no matter what. Because I mean, they're gonna need, that's the thing about your floors. I don't know what all capability, I don't have central monitoring there. No, so I mean, any child that needs continuous monitoring, i.e. any child with any form of vital sign abnormality that's unstable, I would say it needs to at least be rapid to the at least PII status, but I would call them first. Like I wouldn't, it's different. That's a difficult scenario to say because like it's 2 a.m, you got a kid who spikes a 104 fever and all of a sudden their heart rate's 200. What are they admitted for? Or did they just get there kind of thing? Is this something that we can give a dose of Tylenol and a bolus of fluids and just reassess that patient? Well, what do they look like? Are they listless? Is their cap refill okay? What are these other things? Do I have 30 minutes, to can I give them a quick bolus and kind of see how things change? But in the scenario of where you are in your level of training, I would have a conversation with somebody who's truly in charge and be like, yo, here's what's happening. Here are the things that I see. Here are the things that I want to do, but I don't think the kids can stay here. And so other therapies, including hydrocortisone, should guide your therapy. So in summary, SIRS isn't great, but it's all we have for the moment. Beware persistent tachycardia for everything in life in pediatrics. Okay, I've had my own personal cases. I've reviewed, probably at this point in time, hundreds of cases of, either bounce backs or bad outcomes or something that was missed in some way, shape, or form. I'm not saying it's 100%, but there's a very high percentage of these cases where patients were persistently, inappropriately tachycardic despite having a normal temperature. Okay. I think that heart is sensitive for things that are going on. So if you got a kid who's got a temp of 98.6 and a heart rate of 185, you better figure out what's going on because there's something going on. Okay. I don't know if they're just abused and in pain. Okay. And have a femur fracture that you haven't found yet or something else that's going on, but usually something is going on. Once you recognize sepsis, once the computer recognizes sepsis, once you discuss with your nurse who maybe has a concern, who calls you in the middle of the night saying, hey, this kid doesn't look that good, the heart rate's 190 and temp just spiked up to 103, go lay eyes, have a conversation with them and kind of see what's going on. Make sure you give early antibiotics. Don't be afraid to start vasopressors if you're not improving. But always think about hydrocortisone. Just continuously reassess these patients. Whenever I have a septic patient, I am literally in and out of that room probably every 5 to 7 minutes. Like I'm back in there just checking to see what's going on. I had a kid the other day that was in the resus room that had multifocal pneumonia, and we put him on Vapotherm, and she looked like a peach. Okay, came in SATs at 74%. We threw her on 15 liters of flow, 70%. She slowed down, looked great. I went back in there 5 minutes later, the Vapotherm had gone off. Okay, just off. Sitting there, sat in 74% by herself, chug-a-lugging. Parents in there like, she looks worse again. Yeah, she does. Because the Vapotherm just broke. All right, so remember early goal-directed therapy is like something that people hate in the adult literature, but it is something that is very, very easily done and seen in pediatric populations. We have volume, we're supposed to give 30 mLs per kilo to any adult patient that comes in that has sepsis. And all the residents are always like, this patient's got kidney disease. What am I going to do? Flood the lungs? If you flood the lungs, intubate them. You love doing procedures, man. This is what we do, But you want to basically kind of early goal-directed therapy, including normalize your mental status, normalize vital signs, make them look better. Okay, close the gap, close the lactic acidosis, maintain normal glycemia, and then make them pee. Any questions, comments, concerns? So I typically, so when I do it at a couple different places. Usually I start kind of in the nail bed area, but I also kind of, as I'm doing it, I kind of go up more proximally just to kind of check and see. And I also check centrally, you know, and I'll check on their chest. I want to see if there's a difference, like, because that gives you an idea of, is this, you know, is this okay, but this is really not. And so are we in cold shock right now? You know what I mean? Or is this just a normal neonate who's got cutis marmorata, whose mom has not wrapped them up appropriately and they're freezing, you know, then that, you know, that's a completely different case scenario, but you know what I mean? So I check in a couple different areas. Typically I'll check here, I'll check proximally on the extremities, and I'll check central. All right, everybody good? Any questions from the Zoom world? No? All right, cool. Well, I guess we're done. All right, does anybody want some bad news? Okay, I'm leaving. So I'm taking a new job. Yeah. So I'm actually leaving clinical practice altogether, which is, I know, is crazy. But yeah. So I'm going to work for the Healthcare Innovation Department as an administrator for Blue Cross.
Will you stay until the third years graduate?
Yeah, I'm done through. So I'm here through July 31. So.
Yay!
So after July 31, I will not be the director of the PTR anymore. I know they're actively recruiting for my replacement, but I'm sad to go. I'm excited to go, but I'm sad to go. You know, I love clinical work and I love everything that we do, but it's a really good move for me and my family. So making the swap. So, all right, everybody.